to identify and monitor care that we deliver to our women. So my project was looking at key stakeholders and their opinions of the acceptability of using her data and focusing on the postnatal period. But given the fact that there's a very mixed audience here today, I thought I'd start with a brief overview of the clinical problem and then the data sort of infrastructure and solution that we were presenting. So I know that my title says postnatal period, but let's talk about pregnancy to start with. So pregnancy is actually a big stress test on the body. In fact, it demands, there's a huge increased demand on all maternal organ systems, for example, a large demand on the cardiovascular system. And some women may actually develop complications in their pregnancy because of this. So they have an increase in high blood pressure, gestational diabetes, they might develop preeclampsia. And these can go on to complications like preterm delivery, babies that are really, really growth restricted at birth, or small or very large at birth. And unfortunately stillbirth, so that's the loss of the baby after 24 weeks gestation. And whilst most of these complications usually resolve after the birth, this stress test can actually reveal some underlying cardiovascular dysfunction in mums that they might have actually got a lot later in life, but because the pregnancy is exacerbated those. And there's a growing body of evidence that mums who experience some of these complications or poor outcomes actually have a much increased risk of developing cardiovascular disease in the next 5 to 10 years. Which sadly only increases with the recurring events in subsequent pregnancies, and we know that most parents have more than one child, and if you have any of these complications, you have a higher risk of getting Unfortunately, vital signs in the postnatal period are often, I'd say, mismanaged. They're put down to, oh, it's just your body recovering back from having had a pregnancy, so your vital signs might be all over the place. But sadly, cardiovascular disease is the leading cause of female mortality worldwide. And in the UK, we actually assess cardiovascular risk for women from the age 40 plus every 3 to 5 years. But if you think the average age of mothers at about late 20s, early 30s, 21, it was 30.9 on average. That's 10 years too late, and they will have actually already been experiencing some of those events or diseases. And this is important because 75% of premature CVD is actually preventable through risk factor modification if you're early with your treatments. So I've kind of highlighted a glowing window of opportunity there in terms of your postnatal period in maternity care. NICE obviously recognises there are guidelines in place that after you are discharged and hand over to the community midwives, mums have the opportunity to see a GP at 6 to 8 weeks postnatally, where they have a health assessment of their physical and mental health and are given advice on future contraception. However, 2 national cohort studies have shown that despite that, looking in the 12 months after childbirth, nearly 80% of women had a consultation, but only 56 of them were documented as postnatal review. A more recent study found that only 60% had a review within 12 weeks, and as little as 40% only recommended 6 to 8 weeks. And there was a huge disparity in terms of women from deprived areas, young mothers, and actually ethnic minority groups that were less likely to have these checks at all. I've repeated this analysis looking in Greater Manchester in our area, and it's a very similar story. Looked in more recent years as well, and how the COVID pandemic affected it, and they reduced by 30% in the pandemic. And whilst they have recovered to pre-pandemic rates, still there's a large proportion of women who aren't getting them in the recommended time frame. So we need more robust methods to better identify women postnatally, particularly those who are at an increased risk of developing these complications, because evidence has shown that if you get better control of your blood pressure, your weight and diet and exercise, etc., within those first 6 to 8 weeks, your chances are much more reduced in the long run. So as I said, I'll talk about the solution. So in Greater Manchester, I don't know if anybody's aware of the Greater Manchester Care Record, so this app went live during the pandemic, and basically it's an infrastructure that links up patient records for direct care. So a clinician can search for a patient and get a summary of their medication, current allergies, recent test results, and it can help personalise the care that they give at that time period, bringing data from different resources. However, at the moment it's highly populated with primary care data. When you look at the data coming in from the trust, it is very much basic. They were admitted, discharged on these dates, and this was their main sort of area of speciality, like maternity. But the information about what happened during their antenatal period or their interactions, complications they may have developed, and outcomes are not linked at the moment. So this led to the project of, well, if we could build an intervention that would use this data, link it up, build risk prediction algorithms that were able to identify women with an increased risk of cardiovascular disease postnatally. How acceptable is this to members of the public, service users, and clinical teams? We had the main aim of, therefore, developing two diverse groups, one of public representatives. They could have been existing users or potential users of maternity services, partners too, who just are passionate about maternity services in Greater Manchester, as well as clinical representatives working in Greater Manchester with the focus of asking GPs and midwives who deal with the mothers in the postnatal period to come along. Within these groups, we kind of wanted to get the current status quo of their experiences of postnatal care, and then as well as I said, the guidance and the acceptability and appropriateness of the planned intervention. So these are some of the methods. Go through these quite quickly because they're fairly standard after ethical approval. We recruited via social media, so convenient sampling. This is an example of the patient advert on social media. If they got in contact, they were given a much more detailed patient information sheet and at least 48 hours to review that and ask any questions. And then if they have to, if one consent to them coming on to some of the workshops. We decided to run the clinical and public workshops separately so that there was freedom of speech in terms of what was discussed in these, and all participants were compensated for the time. Each workshop was sort of designed in a way that we would run through a series of PowerPoint presentations, either an overview of the project and then some educational materials, and then a time for question and answers, and then followed by an activity, which were all purposely designed to collect their views and opinions, and involved as well roundtable discussions, as well as getting them to write things down based on prompts. All data was collected by use of a co-facilitator scribing, as well as backing in anything that the participants wrote down. And then quite standard analysis. Maybe I should have got in touch with some of the natural language processing to make a less of a burden on this, but it wasn't a huge sample, so it was okay. But a thematic analysis approach was used, so starting with familiarisation with the data with initial code sets to get a thematic map. And then we applied some sub-themes if the theme was quite a large one, with formal descriptions and names, and then supported with patient or participant quotes. And then we've reported this using the core key guidelines in the manuscript. So the interesting bit, the results. So I was really pleased we were able to contact and get 27 public contributors to attend. The majority of these were female, which was not surprising to me given the nature of the topic. But I was really pleased that over 70% were from ethnic minorities, as this population actually had that increased risk of developing complications in pregnancy, as well as therefore long-term cardiovascular disease. The clinical teams, we recruited 7, and we had 4 GPs and 2 midwives and 1 health psychologist who works in primary care for women's health. So I guess there were multiple activities, but the 3 main ones I'm going to present to you for the interest of time. The first one, like I said, was status quo. What is your expectations versus reality of postnatal examinations? And gain an understanding of what they experienced. So I've highlighted here in blue, I guess, more themes that related to the clinical workshops that we did. And they really highlighted that, limited clinical resource in primary care, they're overworked, overburdened, and appointments are only limited to a 10-minute consultation. Unfortunately, there was a sort of idea that primary care practices work on a sort of comparator of how well you're performing on metrics. They're called QOFs, Quality and Outcome Framework, and they get financial reward if they meet these targets. So they did admit that unfortunately some of the behaviours might be more driven to focusing on things that are in QOF, and there are none for maternity health in primary care at the moment. They also said that there's ineffective systems and processes, so they rely heavily on discharge notes from the hospital, which are often incomplete, sometimes don't deliver on time or go astray. And depending on which GP practice, they operate different ways, and some rely on GPs to review these, but some rely on admin staff, and depending on the experience of admin staff, something documented in those discharge notes might be missed, and therefore the patient isn't prioritised for an appointment. Mums, they very much thought that there was low attitude to their actual health. If they went with a baby, it was very much turned into a baby-focused appointment, and there wasn't the opportunity to offer up things about how they were feeling. It felt like a tick box exercise, going off this list, not very personalised towards their needs and values. Some mums had no knowledge about the postnatal examination and hadn't actually been to one, and some definitely, when they got there, they didn't know what to ask, like they had no idea what questions to ask. And some new mum syndromes, they might have been offered an appointment, but they were just tired and forgot to go, so they didn't actually get one in. So clearly there's a need, and it was emphasising what I was, clearly there's a need and an emphasis for a better system to improve this and actually get those mums who have a higher risk to see in time. So the next main sort of activity and discussion that we had with the participants was about the acceptability of taking secondary care data through this infrastructure and linking it, using that data in a secure environment to develop risk prediction algorithms, and then their attitudes and opinions of that. So 4 main themes came out from this. Obviously everybody was really supportive actually. One patient, female patient said, well, how can we improve if we don't have research? Data needs to be used for this. But obviously there were some concerns about talking about taking data, so inappropriate use of the data, risks that mums could be identified, and it's quite a sensitive subject where very personalised things may have happened to individual patients. So risk of who's got access to that data and accidentally leaking or unintentionally or potentially to end up harming individuals or communities was a big concern. Some were indifferent. They thought it was already linked up, and so therefore didn't really have an opinion for or against necessarily, and thought, yeah. But we designed a workshop in this particular part of being quite, well, here, let's talk about your concerns. And then solutions. So they came up and they were quite entrepreneurial about, like, well, maybe we could go out into the community and campaign and go to individual communities about and better education about the data, that it's de-identified and that there's no risk to them and it's in a secure environment. And people who are using the data are trained and would be appropriately accessing it. And the final thing that we did with the workshops was to talk about a digital tool or an intervention to gain an understanding of how acceptable that would be, and about identifying winning based on risk. And there was a huge potential benefit, particularly with the clinical support team. They were like, this will really help our work if it's done appropriately. And they suggested other things, like they needed an action plan there, not just a risk score. So if you tell me this woman's high risk, what do I need to do about that? And so, suggested having, well, get the blood pressure under control in the first 6 to 8 weeks, see them at 3 months, see them at 12 months, and annually until they. That also highlighted that there was this clinical continuity then. If they knew there was an action plan, they'd be seeing them again. Patients were very much in support of that. And we talked about design considerations. So the clinicians were very clear that if it wasn't integrated into their systems and it wasn't easy to use, that's another thing to use in that short 10-minute consultation when they weren't going to use it on the ground. So you needed to work with them in the co-design, which I'm currently doing now. And then we talked about communication of risk with the participants, and this was quite actually varied in opinions. Some were really positive and liked sort of the power of infographics and statistics and having that conversation. Some made them anxious and they didn't like it, and they would much prefer a more positive twist to the message. Don't say risk, have them be so negative, give it, what's the good news, what can I do about it to keep myself healthy? And for the interest of time, I will move on. So I think I've gone through these, through each of the activities in the workshop, but essentially status quo is not what was expected. tick box exercise, lack of comprehensiveness and personalisation. There was some concern about a digital tool and using data in this way, but actually all contributors were supportive if we had better campaigns and education and tailor them specifically to communities to maximise inclusivity and reduce anxiety about it. And they were really, really supportive of actually using risk prediction to identify and streamline processes to get those in at the right time who need to be seen. I just put this up here as a sort of an extra point because for me, I found it a really positive and rewarding experience. All of particularly the public stakeholders, they said that it was educational, they learned so much, and they were going to go to their GP because they didn't have the right treatment after having already had preeclampsia or something. And they were in support of the project, but it was actually providing them with a really safe space. So some of the mums don't talk about this in their culture at all. They do not share the traumatic difficulties and the experiences that they had, so they found it really therapeutic having a safe space to actually talk amongst their community and peers. So that was just an extra win for me of the work. And finally, just thank you to the team. So Siobhan O'Connor was the co-facilitator and did a lot of the thematic analysis. And obviously, thank you to the members of the public and the clinic and the Centre for the Funding.
We have time for a couple of questions.
What are you going to do next to follow on?
Yeah, so at the moment I am working with stakeholders, so clinical GPs, asking and prioritising and designing the actual prototype of the infrastructure that would be embedded into primary care in Greater Manchester, and working with a company who operate the Greater Manchester Care Record.
Okay, so does that mean that you'll be essentially developing a system that will integrate into the electronic healthcare records in primary care, assuming that the information from secondary care goes into GPs, and so that they can then follow up in primary care?
Well, the information, hopefully,
yeah.
short answer. The information will go into a central infrastructure in the GMCR, and the analysis will be done within the GMCR. What we will be implementing is using this company's existing infrastructure. They already provide dashboards to GP practices that they can access, and so it will be sort of a dashboard implementation to transfer that information, but with patient identifiers so GPs can actually click through and see their patients and what risks they've got. But their hope is that it will be able to scan the primary care electronic health records to get, existing comorbidities, existing medications, and all that sort of stuff.
And so are you going to focus still on the cardiovascular disease or other outcomes potentially? Because you mentioned that quite a number of the people that you spoke to had traumatic birth experiences, and that may have other follow-on health effects such as PTSD and so forth.
Yeah, absolutely. So the idea is to be more broad, because speaking with the GPs that I'm working with at the moment, they need to make sure that they're capturing everything in women's health, and so having an intervention that is very focused. For this, it was quite good to have a topic and a case study that patients could actually understand why postnatal health is important, but there is so much to cover in that consultation, so GPs are like, well, can you help us out with everything, not just one aspect of it.
A quick question myself. So I was wondering, because we talk a lot about developing technology and embedding users when we develop technology and algorithms and so on. And you mentioned that most of the participants that you talked to, they didn't have major concerns about the data linkage tool, but some of them did mention something. And I was wondering if there's an opportunity to embed some of those concerns into the algorithm itself, so that the concerns are addressed in the technology that is being proposed.
Yeah, well, I think the main concerns were about their identity being leaked. So if we were to use it as secondary purpose for research, to then be able to build these risk prediction algorithms that would then be built in. So it was more about reassuring them that as a research team and not directly involved with their clinical care, we wouldn't see their identity. And that's something that I think has got lost in translation and miscommunicated over time. So as soon as you start explaining things like that, they're a bit more, oh, well that's okay, kind of thing. And saying to them, the data as well, it's not just the de-identified process, letting them know what that involves. It's not just taking your NHS number away. it's removing the first part, like you only know the year of birth, you remove the postcode, lots of the names, obviously, all that sort of stuff, it's all removed. So all you know is sort of the age of the woman and like top level race categories and one of the 10 CCGs across Greater Manchester, and that's it. And so when you start communicating things like that, they realise that there's probably not that much risk then. And so it's about educating them, really, rather than embedding it into the tool, because it's already within a secure data environment.
Amazing. Thank you so much. Now it's the last presentation of the day.